Welcome. I'm Dr. Phil Louie, and today I'm sitting down with Dr. Thomas Mroz, a spine surgeon at the Cleveland Clinic and the current president of the Cervical Spine Research Society. Dr. Mroz, thank you so much for being here today.
It's great to be here, Phil.
Today, we are going to focus on a condition called cervical radiculopathy. That's something that affects a lot of people and can be really frightening when it first shows up. Let's start at the very beginning. So, Dr. Mroz, when a patient is diagnosed with cervical radiculopathy, what does that actually mean? What's happening in the neck?
It's a term that sounds intimidating, but once you break it down, it makes a lot of sense. The cervical spine, the neck, is made up of 7 vertebrae or bones stacked on top of each other. Between each of those bones, nerve roots branch off from the spinal cord and travel through small openings called the foramen on their way down into the arm and hand.
And what does that feel like for the patient?
The most classic presentation is pain that starts in the neck and radiates down the arm, sometimes all the way into the hand and fingers. Patients also describe numbness, tingling, that pins and needles sensation, and sometimes weakness in the arm or hand. What's interesting clinically is that the pattern of symptoms often tells us which nerve is involved, even before we look at the imaging. Each nerve root has a predictable distribution of muscles and skin it supplies.
So you can sometimes make the diagnosis from just listening to their history, their story, and a physical examination?
Exactly. A careful neurologic exam, checking reflexes, muscle strength, and sensation, gives us a lot of information. The MRI then confirms what we're seeing clinically and shows us exactly where the compression is.
So let's talk about causes. What's actually compressing the nerve in the first place?
There are 2 main culprits. The most common is disc pathology. The discs between the vertebrae act like shock absorbers. They cushion the spine during movement. Over time, or potentially after injury, the soft inner portion of the disc, called the nucleus, can bulge or actually herniate through the outer layer. When that happens, it can compress the nearby nerve root. The second is degenerative change, what we sometimes call spondylosis. As discs wear down over the years, the body responds by forming extra bone at the edges of the vertebra, bone spurs or osteophytes. The spurs can gradually narrow the foramen, an opening where the nerve exits, and begin pressing on it. This tends to be a slower, more insidious process compared to an actual disc herniation.
So can you get both at the same time, both a disc herniation and those bone spurs?
Absolutely. In fact, it's common to see a patient with some background degeneration where a new disc herniation then tips the balance and causes symptoms. The foramen is already a little narrowed, and then the herniation reduces the space further.
So I want to make sure that our viewers understand an important distinction, right? How is cervical radiculopathy different from the term myelopathy? Because I know those terms sometimes get used together and can cause some confusion.
Really important question, and something we see misunderstood frequently. Radiculopathy is compression of a nerve root, a single nerve branch that's exiting the spinal canal. Myelopathy is compression of the spinal cord itself. These are fundamentally different problems with different implications.
So how does that show up differently in the symptoms themselves?
With radiculopathy, symptoms typically affect one arm. It's usually unilateral, and they follow the pattern that specific nerve root supplies. Pain radiating down the arm is very common. With myelopathy, you can see both arms involved, sometimes with legs as well, and you often see more coordination problems, difficulty with fine motor skills, like buttoning a shirt or changes in handwriting, or an unsteady gait.
So if a patient is watching this today and they have weakness or coordination issues in both their arms and their legs,
they need to see a spine specialist. Myelopathy is a more serious condition and timing matters. For patients with radiculopathy affecting one arm, we have the luxury of time to try conservative management first, but myelopathy is different.
All right, so let's walk through the treatment pathway. If a patient is diagnosed with cervical radiculopathy, what happens first usually?
The encouraging thing is, I always tell patients, is that the majority, I'd say the vast majority, of patients will improve without surgery. For most people, the acute, severe pain phase lasts somewhere in the range of 3 to 6 weeks, and the overall episode resolves within 3 or 6 months. So we start with non-surgical treatment.
Okay. What does the non-surgical treatment look like?
It typically starts with the primary care physician. Rest, activity modification, avoiding movements that provoke symptoms. On the medication side, we're often using anti-inflammatory medications like ibuprofen, sometimes muscle relaxers, and occasionally a short course of oral steroids to calm the inflammation around the nerve.
What about physical therapy?
Physical therapy is a cornerstone of conservative management. A good therapist will work on posture, cervical strengthening, and range of motion. Cervical traction, gently distracting the neck, can be very effective in taking pressure off the nerve root and providing relief. We also have interventional options like epidural steroid injections or nerve blocks, which can significantly reduce pain and allow patients to engage more effectively with therapy.
So when does surgery enter the conversation?
Surgery becomes the right answer in a few scenarios. First, if conservative treatment has been genuinely tried, we're typically talking about 6 weeks to 3 months, and the patient hasn't had any adequate relief. Second, and more urgently, if there's significant weakness that's not improving or is progressing. Weakness is the key alarm signal, and it tells us the nerve is being damaged in a way that may or may not reverse on its own. In those cases, we can't wait.
Are there multiple surgical options that are available?
The good news is we have several well-established approaches, and the right one depends on the individual's anatomy and the specific nature of the compression. The most commonly performed procedure is ACDF, anterior cervical discectomy and fusion. We approach the spine from the front of the neck, remove the damaged disc and any associated bone spurs to decompress the nerve, and then stabilize that level with a spacer, either bone or a synthetic material, and typically a small plate and screws.
So that's a fusion. Are there other different types of surgeries as well?
There are a couple other prominent options. One is artificial disc replacement or disc arthroplasty. The approach is very similar to an ACDF, but instead of fusing the level, we insert a mechanical disc that preserves motion at that segment. This is particularly appealing for younger, more active patients. And then there's the posterior foraminotomy, where we approach the back of the neck and enlarge the foramen, the opening, to give the nerve more room. That can be done in a minimally invasive fashion and avoids touching the front of the neck entirely.
So how does a patient know which is the right surgery for them?
Good question. That's a conversation that needs to happen between a spine surgeon and the patient after the surgeon has reviewed the imaging and understands the full clinical picture. There's no universal answer. Each approach has its appropriate indications. What I always tell patients is that the goal is the same regardless of the technique. Get the pressure off the nerve, relieve the symptoms, preserve or restore function, and make sure the surgery is as durable as possible.
Well, before we wrap up, are there other conditions that can look like cervical radiculopathy that patients and clinicians should be aware of?
Definitely. This is one of the reasons a proper evaluation is so important rather than just relying on imaging alone. Shoulder pathology, particularly shoulder impingement, can mimic C5 radiculopathy quite closely, with pain around the shoulder and even deltoid, or the major muscle in the shoulder, can become weak. Peripheral nerve compression, like carpal tunnel syndrome at the wrist, can also look a lot like cervical nerve root problems. The history, the physical exam, and sometimes additional nerve studies help us sort through it.
So it really is worth getting a thorough evaluation rather than assuming the source of the pain.
Absolutely. And that's what a good spine specialist or even a well-trained primary care physician can do. Piece together the whole picture before making the diagnosis.
Well, Dr. Mroz, as we close out, what are the 2 or 3 things you would want patients watching this to walk away with?
A few things. First, if you're experiencing neck pain with arm symptoms, pain, numbness, tingling, and especially weakness, get evaluated. Just don't push through it. Early diagnosis means more options. And second, most people do not need surgery, and that's important. The natural history of cervical radiculopathy is actually quite favorable for the majority of patients. Conservative care works, and we have a lot of good tools to support recovery. And third, if surgery is recommended, the outcomes are excellent. We have well-established, safe procedures with strong track records. Patients should feel confident that if they do need an operation, the goal is very achievable, getting you back to your life.
Well, Dr. Mroz, this has been incredibly valuable. And on behalf of the Cervical Spine Research Society and everyone watching, thank you for your time and your expertise.
Thank you, Phil.